So next I'm going to talk about abstract 2377. The title is A Hierarchy of Adverse Prognosis Quality Markers After Curative Intent Resection of Non-Small Cell Lung Cancer. Now that's certainly a mouthful to say, but step back and take a look at what this is really asking. If you think about it, all of us know that everything we do about treating lung cancer patients is entirely based upon the stage that we assign them. So how do we know the stage is correct? Well, a lot of that falls on surgeons with early stage disease and on doing an adequate resection, an adequate lymph node sampling, and getting good margins. The ASLC has done an incredible job taking the lead in defining what is a complete resection. How do we know, if the surgeon says it's a complete resection, shouldn't we be able to tell that by the data that's out there? And so the data that's been proposed in an article published in the Journal of Thoracic Oncology, our working group from the ASLC, has suggested that it's not just whether the surgeon says it's a complete resection, appropriately so. It's whether an adequate number of lymph nodes has been evaluated. It's whether the highest lymph node station was positive or negative. It's whether complete resection was performed. And the ASLC has used these things to demonstrate that these things truly have an impact upon survival of the patients. Not unexpected, there's been a large body of data suggesting that good lymph node dissection, getting an R0 resection, all these things impact patients' survival. This is not only important for surgical outcomes, but it has incredible implications for how we treat these patients from a multidisciplinary approach. The addition of adjuvant therapies such as adjuvant chemotherapy, adjuvant targeted therapy now, or adjuvant radiation is completely dependent upon the surgical quality and upon the quality of lymph node dissection and identification of at-risk patients. So I was really happy to see this abstract and to see what it proposed to do. They looked at patients from a well-studied the Mid-South Quality of Surgical Resection cohort. These were patients from 2009 to 2020. And they looked at those factors that we had talked about. A negative margin, an appropriate lymph node dissection, non-invasion of the highest mediastinal lymph node station, no extracapsular invasion of the lymph nodes. Remarkably, only 33% of patients had a complete resection by this definition. And over 70% of that was because of inadequate lymph node sampling. So we as surgeons still need to do better. We need to do better with lymph nodes because we know that will identify patients with more aggressive disease. Now that we have better systemic treatments, that's incredibly important, and I can't emphasize that need enough. Incomplete resection, as judged by these ISLC standards, was associated with a 160% increased risk of death. And that's pretty remarkable. That's something we should tell our patients. There was an 80% increased risk for a wedge, a sublobar resection, 65% increased risk if no nodes were sampled, and a 37% increased risk of dying if there were no mediastinal lymph nodes sampled. Obviously, there's lots of factors that go into this, and these are largely associations, but they're remarkable to me nevertheless. This really has incredible implications. Surgery has to do better. Too often, we're not doing a good job. We're not doing the job that we're supposed to be doing. This may jeopardize our ability to interpret neoadjuvant and adjuvant trials. As all of these amazing medicines that we have move into the neoadjuvant space, the adjuvant space. If there's so much variability introduced by the surgical techniques, we're not going to be able to interpret the true benefit of some of these novel drugs as they move into early stage disease. There's got to be surgical quality control for all of these trials. This also has critical implications for alternative to surgery. Stereotactic radiation therapy, whatever we think about it, doesn't get the lymph nodes. And so that leaves some of these patients in this set at risk. That suggests at least that the lymph nodes should be evaluated, perhaps invasively in many patients, so that we can be sure that stereotactic radiation is the right choice. I think the bottom line of this abstract is that we can do better, and it's beholden on us to do so because patient survival depends on surgical quality.